This is the second part of Chapter 19. And remember, parents are our patient as well. Having them involved, keeping them informed is part of our job. That's not extra. That's the basic job we're doing. So another thing we want to do is normalize the hospital as much as we can, which means following a child's routines at home as much as we can. Now, not everything can we do that, but in those things we can, we want to. It's good if we can have their time structured. They get up at 8, they eat breakfast at 8:30, they go to the schoolroom at 9, something like that. Have a schedule for them. And having them do their own self-care. If it's things they would do for themselves at home, brushing their teeth, dressing, then tell them to do it. Make sure they're doing it, but they should do it at the hospital too. We don't want to have them take on that sick role. Schoolwork. It's hard enough to be away from school for a length of time, and then to go back and be behind would make it even worse. So one nice thing at Valley Children's, we have a credentialed teacher in the classroom who will contact their teacher, the patient's teacher, in order to make sure that we keep them up on their schoolwork. And friends and visitors, they're used to interacting with their friends. They still need to know, what's going on in their classroom, in their soccer team, and, those things that they do when they're not in the hospital. So having them keep up with friends is good as well. Here's just an idea about making a daily schedule. So this kid has breakfast and then takes meds, then has therapy. If you have a child who's too young to read, you can do the same thing with pictures. And having family involved. This picture said family involvement, although she looks like she works for the hospital. But having them involved is really going to help kids. So family is our patient as well. It's not just the child. So we do need to do an assessment of the family. How are they coping? How are they doing? Do they need a social worker involved? Remember, Valley Children's is regional. We have kids from hours away, literally. Our region is very large, and so these families may need help. There may be kids several hours away that they need to get back and forth. So use the social workers, make referrals as needed. Discharge assessment and planning. What are they going to need? And we need to make sure we've got the supplies for them and that they have the training in order to use those supplies, and that they also just have the confidence, the comfort in being able to do whatever we're sending them home with. So having parents involved in the care is a good thing, making sure they stay informed, and then again preparing them, figuring out in advance what they are going to need. Are they going to need a wheelchair at home? Are they going to need other special formula, and getting those things ready for them. So this part's on children in special circumstances, so different parts of the hospital. So if we have a child who has surgery, but it's as an outpatient or ambulatory surgery, that's a nice thing. There's no overnight stay. That's going to keep the costs down. That's going to reassure the parents a lot that they'd rather have the child home than in the hospital. But it also doesn't give us a whole lot of time to prepare the child beforehand, and it doesn't give us a whole lot of time to do discharge teaching. We've got to make sure we do really good discharge teaching. So if the child hasn't been prepared well in advance and they're sitting in a waiting room getting more and more nervous, that's not a good thing. So as much as we can, if we can get them in a few days before and show them what to expect, that would be helpful. Kids in isolation. Don't ignore them. It's easy to ignore them because you got to gown up every time you go in, right? So this makes hospitalization that much more stressful. For a young child, when they see you coming in with all that personal protective equipment on, it looks scary. They don't know what's going on. So we do have to make sure they understand what that's for, and that it doesn't mean they're worse than they think they are. It also is very easy for them to get left alone in there because it is a little bit more effort to have to gown up. So let's make sure we're not leaving them in there alone, that sensory deprivation. Emergency. Something has happened and the child comes into the emergency room. So we are going to have that admission counseling. We're not going to be able to do things in advance. And if we do need to do some counseling, explaining, we're going to do a postvention because we can't do an intervention beforehand. So after the fact, we're going to go back, see how the family's dealing with it, see what needs they have, and help them. Intensive care unit. Sometimes the family's very stressed that the child's sick enough that they have to go to the ICU. So we first need to deal with that. But then when the child gets better and leaves the ICU, that can also be very stressful for parents because they've gone from having a one-on-one nurse who's sitting there at the bedside or looking through the glass door the entire time their child's there, to now the child's in a room and the nurse is running around between 4 rooms. So sometimes they feel like they get used to that higher level of having their child observed more closely, and then they're not very comfortable coming down. So we need to make sure they know what's going on, that we're dealing with the family's emotional needs as well as the child's physical needs, especially when things are not going well. And that's the end.